listening to Radio Maria Yatsani Voice.
Oh, Queen of Radio Maria, pray for
It's a warm welcome, our dear listeners and viewers, and welcome to the Lusaka Apex Medical University Radio Grand Round. My name is Stephen Chongompuku. If you're joining us, we are live on Radio Maria Lusaka and Radio Maria Chipata, and also Lumen TV on channel 101. And this is a program that brings you different topics that deal with health matters. We want to make sure that you are blessed with the information on health issues so that you know how to live a healthy life. In the studios, I have my two guests, my usual two guests. Professor.
Yes,
Mr.
Mr. Chongo, good morning. Good morning, viewers and listeners.
Mm-hmm.
Thank you.
Thank you so much, Madam Shinondo.
Good morning, Mr. Chongo. How are you?
I'm very okay. I'm sure I want to talk about the enrollment before anything else.
Yes, above all else.
Yes.
So, just as a quick recap, welcome to our listeners and our viewers to the Lusaka Apex Medical University Grand Round, Radio Grand Round, alongside Yatsani Radio and Lumeni TV. Now, this program is part of skill set building within our students, but especially just to further their education, but also to help the general public learn more about medical issues, but more so from an anatomical point of view. So we usually start from head to toe. We go system by system, okay, piece by piece, so that even the public are aware of what their body is made of, how it functions, and what could go wrong, and how these things can be managed. Now, we're currently in the respiratory system. So we've moved from the nose to the pharynx to the larynx, and today we're in trachea and bronchi. So we just need to remember it goes downward from top to bottom. Now, we're currently enrolling for our July 2022 intake as well as our January 2023 intake. So for those who are interested, you can apply. Either visit our website on www.lamu.edu.zm, or you can come through our main campus along Kasama Road in Chalala. Now, just a quick touch on, once again, the respiratory system. Just a quick recap, because as Professor Lambert says, repetition is always the best way to learn. So, nose is the entry point of oxygen. Pharynx is the passage, but now this passage connects the back of the nose, the back of the mouth, as well as down into the throat, or further down the throat. Then from the pharynx, we have the larynx. Now, once again, this is where air as well as food passes. Now, this is where the interesting division happens between, is it liquid or is it gas or is it solid? So it's a very intelligent part of the body. So today we'll now enter the trachea, which again, this connects to the larynx, which is part of your throat, and then goes down into the bronchi, which we will also touch, which is part of now really taking in oxygen into your system.
Okay.
Me too.
Right.
Very
Hand
good.
over.
Professor, yes, now you can do the
Thank you very
introduction.
much. As usual, let me start by bringing greetings from our Vice Chancellor, Professor Evariste Njelesani, our CEO, Professor Peter Mawa, and indeed my colleague, Professor John Mudenda. They are all greeting you, and the registrar, and indeed Dr. Msidi. The registrar and Dr. Msidi are prayer warriors for the institution. We always remember them. The deans, the class representatives, and the students wherever you are. I hope you are listening. And you know the song we start with always is Amalumbo Kudilesa. That is extremely important because we do want to encourage our students from early age of profession, health profession. They must pray first and work hard to look after God's people. That is the task. Knowledge and excellence. But acquire knowledge not only for your own sake, but for the sake of the clients you'll be looking after. So be very thorough. Pray, pray, pray. Prayer is the most important because we are going to look after God's people, people created by God. Through Adam and Eve, we have all grown out into billions. But the origin of human life is the creation of Adam and Eve. That we should be looking back. And we are biological bodies, things may go wrong. So should there be disease developing in the respiratory tract, the system that received life, breath of life, that's the system we are handling now. So trachea is what we are going to discuss today.
Wow.
Thank you.
You can even take it up now.
Yes. Now, trachea is now where we have left the larynx. You remember supraglottis, the glottis, and the subglottis. Below the larynx, there's the trachea. And the larynx is 4.2 centimeters. The trachea itself is 10.5 centimeters. And the diameter in men is 2 centimeters. And in women is 1.5. There's slight difference. We mention this, and in children, particularly in children, our students should know that a 3 months old child will have trachea different, 3-year-old, 4-year-old, like that. So when you are choosing a tube to intubate a child, know the age. We say 3 years child is a 3 millimeter size. 4-year child is the 4 millimeter size.
Doesn't matter.
It doesn't. You look at that, but a boy and a girl will start differentiating. But these are babies. Why we are saying that is when a child comes and want to intubate, know the right size. It is said that after 4 years, every year, 5 years will be 5 millimeters. 6 years will be 6 millimeters. So your age will guide you. Don't choose a big tube. You may cause trauma when you are doing endotracheal tube insertion. That is extremely important. There are conditions where your child is very sick or an elderly person is unconscious and you want to push in the tube. So the length now, the larynx, when you enter at the level of epiglottis, we lift epiglottis. We look for the folds. The vocal folds, they are whitish because they don't have submucous tissue. They are not vascularized, so they look whitish. So anybody intubating a patient should look for those and then push in the tube according to the size which you think will be safe to insert. And the length you should also be knowing that where I am going in the larynx, it's 4.2 centimeters. I'm going into the trachea, which is 10.5 centimeters. You are adding and gently pushing in the tube. So that's the purpose of knowing this part. We use it a lot in medicine. critically injured patients, unconscious patients, babies who come very sick, we use this way to support, to deliver oxygen. Because the purpose of the trachea, the whole larynx and trachea, is to deliver atmospheric oxygen deep to the alveoli. We also do tracheostomy in some cases. If, for example, the larynx is blocked, we open below the thyroid, below the Adam's apple, below the cricoid, where the larynx is ending. We palpate for the trachea, and we open the trachea to do tracheostomy, so that the patient gets the air that is now blocked in the larynx if there's a lesion. So that is very important. Sometimes infection from the pharynx, the larynx can make swelling which can obstruct the way. So our students should know, if you get a patient with quinsy, for example, and the blue is restless, is breathing, the breathing is very difficult, there's a stridor, you will plan to do tracheostomy, to open the trachea, put in the tube, and then give oxygen. The patient will have been saved. So that's how it is. Then as you go deep, the right bronchus, principal bronchus, is larger but shorter, more straight. So when a child has inhaled a coin, for example, where do you look for a coin? The commonest, any foreign body going into the airway, the commonest passage will be in the right bronchus. It will go there because it's wider, is more straight and shorter in terms of, so you can look for a foreign body and pull it out to open the airway. The left side, left bronchus, is 5 centimeters, double the size on the right side. And there it's more oblique, it's not straight, but it's longer. Sometimes when there's aspiration, you have to look both right and the left side when you are doing endoscopy, and also suctioning of the airway. So a lot of procedures which can save life are taking place in that. Then our students, when you are doing a ward round or during examinations, you are being examined by your consultants. They will ask you and observe you. Do respiratory system examination. And they are all standing and watching you. So please take it this way. The first maneuver, first move you take is to palpate for the trachea. That's why today's topic is extremely important. You may lose the marks and fail. If you said, okay, examine the respiratory system, they're all watching. The first maneuver, the first move you should take is to show the examiners that you are starting examination of the respiratory system by palpating for the trachea. Once you do that, they know you know what you are doing. Yes. But should you now start from the end of it, examine the respiratory system, and you are taking a stethoscope, you are now hearing the air, you have lost it, because examination is the inspection, palpation, percussion, and auscultation. These steps are really applied in the respiratory system when you are examining. So our students should follow these talks so that they understand the basis. Trachea is very central. Even when palpating, it must be central. If it's not in the center, then you must say, I have palpated the trachea, is it deviated to the left or to the right? Immediately, you impress your people around you that you are correctly doing things correctly. Because immediately will show you now that inspect the breathing in and out, the expansion of the chest. Breathing in, the chest will be expanding. Breathing out, the chest retracting. So you compare right and left. If trachea is not in the central position, in the midline, then you inspect, you'll find that one side of the chest is not moving. Maybe the lung has collapsed, or there's a fluid, or there's a blood on that side. And the trachea may be shifted from its normal position. This is how important it is. We are spending time today to look at the trachea. And this trachea doesn't collapse because it's not just a muscle tube. Creation made sure that this passage does not collapse easily. So Adam received cartilaginous rings in the trachea. They are cartilages, rings, to keep it open. And from that creation, all have inherited, like the Adam's apple. I can see with Mr. Chongo here.
Yeah.
Very good.
Very pronounced.
Very pronounced. And when you are swallowing, it can move up. So we also observe when swallowing, if there's a goiter, for example, there's a swelling in the front of the neck. One of the signs our students must always remember is to ask a patient, can you please swallow your saliva? When a patient is swallowing, the thyroid growth, thyroid gland, it will move with swallowing. Then we know it is from the thyroid. If the swelling is not moving with the swallowing, we ask a second question. Can you protrude your tongue out? So the patient, as he starts protruding the tongue, if that's when it moves, the swelling in front of the neck, that's when it moves, then that swelling is not thyroid, it's not from thyroid, it is the thyroid growth or cyst. So that maneuver, our students must know this, because you want to demonstrate anybody with a swelling in front of the neck, these are the key questions you will be asked. Thank you.
Actually, Professor, speaking of swellings on the front of the neck, do we have cancerous swellings?
Yes, we can get thyroid. Thyroid can enlarge. It may be benign or malignant. It may be toxic or non-toxic. So our trainees, our doctors do know, whenever we have a swelling in front of the neck, the health worker will want to check, is it benign, And if so, where was this patient, born, grew up, where? Because in Zambia, we have certain districts which have got low iodine content in the soils, and those districts tend to have more goiters, So we want to take that history. And then we want to observe, is this toxic? If it's toxic, you do a certain test. For example, look at my finger, you follow the finger up, look down, then there will be lead lagging. Then you know it is toxic. You feel the temperature is warmer, pulse rate is high, patient has tremors, then you know it's toxic. Heartbeat is very rapid, then it's toxic. Non-toxic, these features are not there. But the malignant one will be the one which will grow rapidly, even when there was a benign one, and you have kept the thyroid for many years. But if the size is increasing, is rapidly increasing, be suspicious that it may complicate with malignancy. And the malignant one tends to affect laryngeal nerves. Recurrent laryngeal nerve, which we covered last week. Recurrent laryngeal nerve, malignant goiter can infiltrate those, and the voice starts changing. The patient now is producing hoarseness, hoarse voice. And that you would be able to say, and when you palpate, we say the malignant goiter is as hard as you palpating your forehead. That is malignancy. It's hard, and it may be multinodular. Then you are worried because you have to do total thyroidectomy for malignancy. For toxic goiter, you do subtotal. You only leave a small strip at the back of the thyroid. You leave those to protect the parathyroids. Yeah, so a surgeon will leave a strip at the back. But because it's toxic, even the small strip we have left behind, it will produce thyroxine for human use, for body use. That is okay. We call it subtotal. If it is just for cosmetic reasons, we just do partial thyroidectomy to reduce it to normal size, because the patient says, I don't like it, it's looking ugly.
Yeah.
I want it reduced, you know. So we do a proper incision below, especially ladies. You know, ladies, they don't like scars. So when you are operating, we have to be very careful. We even do subcutaneous suturing to minimize the scar tissue. And then we reduce it back to normal size, cosmetically acceptable by the patient. But with all this, we must prepare blood grouping and cross-matching, because the thyroid can bleed.
Can bleed. Wow. Mungakambeko pang'ono manje
Mchinyanja, yeo. Za lero tilukamba za kokoko uyu, kokoko mene tiyuzinga popuma paja. Kokoko na ntchito ulola mphepo kuti ichoke mphuno, ichoke kumbuyo kwa mphuno, ilowe pa voice box yapa pamene tikambira, pa larynx, then ilowe mu mpaipi ya mphepo, njira ya mphepo, mpaka ikafike kwa papu. Lomba ngati njira ili bwino itsekuka bwino, mzaona patient apema bwino mokhazikira. Ngati rutsekeka, mzachimva chongo popemera mkati o popemera kubwalo, ndiye kuti njira irutsekeka. Mwino kosomola ndiye kuti njira siri bwino. Ngati munthu ali bwino, alikale tero wa bwana wano alikale, mukawerenge kuti apema kangati pa 1 minute. Mzaona kuti ni 16 times. 10 kasanu na kamodzi. Ndiye kuti munthu ali bwino. Ngati alupema kothamanga, chilipo chachitika mchifuwa, kapena mapapu siyalu 7 za bwino, one side or both sides. So perekani kuchipatala munthu wotero, ngati akosomola, ngati avutika popuma, ngati mauya chinja ya lusasa, msakhazikire, perekani adokotala akamupime, akaone chachitisa zonse izinchiyani. Wena mwa asima, njira za mphepo zimavalika zichepa, so sape mabwino, musakhazikire, zengerezo analinda kwau, musachedwe, muzifika msanga kuchipatala. And boma laika konzeru, Ministry of Health inachita open my health centers everywhere. I think societies now, they are nearer to a health center. Yeah. So udwazikira pa nyumba, ya ipitani kuchipatala azapima. That's why tulimbana nayo university kuti tuchite treni wodziwa mwini wa ntchito wazinchito anyantchito vamvipatala kuti azividziwa vonse vitiluphunzitsa akathandize imwe vanthu wachilengedwe cha Mulungu. Zikomo.
Zikomo kwambiri. Any follow-up questions to what Professor said?
Plenty. Okay. But the first thing I can point out is, again, for the sake of our audience, I'd like people to have a reminder of what some of the words Professor is using. So, just as a quick recap, what is to palpate?
Palpate, yes. To palpate is to feel. If, for example, you are palpating the trachea, the position, and you ask the patient, say 99, and that resonance of the voice, you will feel it. You feel it. That's to palpate. You also palpate the thyroid gland. A palpation, does it feel soft? Does it feel firm? Does it feel hard?
So now to connect with what you were saying, or what our LAMU students should do when checking, testing a patient, that also means the audience should also know what to expect from their doctors.
Yes.
So meaning
he's doing this maybe.
Yes. But one thing you said that stuck out is once a practitioner of whatever specialty it may be uses the stethoscope first,
yes,
then that means a few other stages have been skipped.
You have jumped these steps.
So it should be felt. Someone says 99, whatever happens.
Yes, inspect first. Inspect, you say, take a deep breath, you are inspecting. Then you say, okay, I've seen one deep breath. Then I feel, say 99, you are touching the chest or the trachea. That is palpation. Then you put your finger down on the chest and you tap on it. That's percussion. And you want the note. If it's hyper-resonant, you know it's air. If there's a dullness, there may be fluid or blood.
Oh.
That's how, yes.
So basically somebody's tapping
You
their
tap,
finger for a type of
yes,
echo.
the examiner puts a finger on the chest and the corresponding area, right and left, to compare. Then it gives you, and for examination of respiratory system, all these 4 steps are very, very important. Then finally, after 1, 2, 3, you did now your stethoscope. You take a deep breath, open your mouth, and you are listening to the left, to the right. To the left, you are comparing all the time.
Wow.
That's fascinating.
Very fascinating, very interesting. And at this point in time, tafika pa ntau ya kukamba naye muomvesera kuti mtume ngati muliko na mafunso. Manambazi ni ya masiku onse tili pa 0972695200 0972695200 kapena pa 0956520277. Mwamasiku onse wa profesa wali muno lero wakamba pali trachea, but ngati muliko na mafunso enangu mungafunse. Hello? 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 Okay, mungatume futi kapena we are not getting that audio from you. The same 0972695200. TS Manje. Hello? Hello? Okay. Maybe we have a technical issue there, but you can, you wanted to say something.
Yes. Professor, I just had a sudden memory. Or one of my fellow university classmates, she used to have an interesting habit. I'm sure sometimes you've noticed some people, they might have that inner itch in their ear. That itch deep in the ear. So now they would, either stick their finger in their ear and they would, back and forth. Then to relieve the itch, then to relieve the itch, you would hear them scratch their tongue on the back of their throat. So now, last week and in some of the previous weeks, you did mention that there is a connection between the throat and the inner ear. You said that there was a connection. So at times, what causes that? And secondly, she made an interesting mention of when she would scratch for too long, she would taste blood at the back of her throat. So it just crossed my mind because I've noticed this is a very popular habit. People would make that, whatever that sound is. So what causes that itch from the throat to the inner ear and to the bleeding? Is it up in the pharynx or where does that come from? Because I take it's friction from the tongue.
Yes. No, I think what you are describing is what we discussed when we were dealing with the pharynx and the larynx. So what we said, the nasal area, nasopharynx, there are a lot of sinuses that open into there. When there's inflammation in the nose, there's also a special tube from the nasopharynx to the ear, which we call it Eustachian tube. That tube is supposed to allow air to fill the ear. Now, when it is blocking, the air is emptying in the ear. There's now pressure from atmospheric air trying to push the eardrum, because the balancing of pressure in the ear has reduced because the Eustachian tube has blocked, so that the itching. So the patient will try to clear that ossetion tube. You know, that's the irritation it's trying to do, the clearing which you are talking about. And because the inflammation around the ossetion tube is irritating in the nose or the oropharynx, that's why they're trying to scratch down there. But that can cause bleeding, you know. That can cause bleeding because you don't know what has caused all that blockage. It will be an inflammatory process. Remember, that's where defensive mechanism was created. The Wadea's ring of defense is in the pharynx. So that is trying to fight the infection, to protect the body, to protect the lungs, the fighting. And in the fight, there's irritation, there's swelling in the fight. So all this, but the most important thing is to make a diagnosis. Those patients should not be at home trying to struggle and all that. The doctor will examine, will include nasal drops to clear, to open up, yes.
Right. Then, now that you've described the anatomy of the trachea, as well as things like infection, tumors, and the like, now, what are the most common ailments or conditions that happen locally in Zambia within the trachea and the bronchi?
Yes, bronchitis. Bronchitis, very important question you have asked. Bronchitis is very common. And it's that infection which has escaped the defense system in the pharynx and is now going down. The laryngitis can occur. Tracheobronchitis can occur and is quite common. When it is happening like that, there's a swelling around there. So when a doctor is examining the chest, you will listen to the breath sounds right and left. And what you'll be hearing is bronchitis. There will be crackles when breathing in and when breathing out. Both breathing in and out, because it's a common passage. So the doctor will tell that, yes, this is now bronchitis. We can differentiate when we are examining. If it is asthmatic bronchitis, using the stethoscope, you can tell. We listen to the chest, right and left, but the difficulties will be breathing out. Expiration becomes difficult. So the noise, the crackles, will be more confined in the expiratory phase of the breathing. If the airway is obstructing, like the larynx is obstructing, the breathing is difficult when you're breathing in. So the listening doctor will listen, say, when breathing in, the patient has difficulties, then it must be an upper way obstruction. If his breathing out is difficult, is there a history of asthma in this patient? But just by listening to the breath sounds, it's so clear. When it's bronchitis, the difficulty will be both breathing in and breathing out. Then it's tracheobronchitis. Right. So that machine works very well when you listen to a patient.
Okay, let's try to see if we have a call. We were experiencing a technical hitch, but we hope we are okay now. 0972695200. Hello? 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 Okay, we seem to have
technical
problem this week. But anyway, the conversation continues. So, when that...
I hope your mboyas are listening in Shipata.
They are.
They are? Okay, good.
And hope could soil yao in iodine.
No!
Now, talking about that, the same goiter.
Yes.
Which one is dangerous as in the cause? Because you explained two types.
Yes.
Yeah, but which one is more serious?
You know, there are four types. We say the benign type, goiter, non-toxic. There's the toxic one, and also the malignant one. So there's the benign, there's the non-toxic, there's toxic, and the malignant goiter. The most dangerous is the malignant one. Because even when we are treating, we have to remove the entire thyroid because it has become cancerous and it can move. It can even go to the brain, to the head. The thyroid malignancy is dangerous. It can spread out. So that's why we have to remove it 100%. But when we remove, we have to replace what the thyroid gland was created for. It is to produce thyroxine. So before you do total thyroidectomy, in your pharmacy, you must order enough thyroxine for your patient so that we don't run out of the thyroxine.
Oh, so now?
But the second difficult one is the toxic one. Very, very, again, very uncomfortable. Patient is sweating, patient has tremors, the heart palpitations, and gets exhausted very easily because the thyroid gland is overproducing. And there's a lot of stress in the body. So that's the one we do subtotal thyroidectomy. Only to remove almost everything except a strip at the back of the thyroid so that we keep the parathyroids safe. Don't remove them because it will cause more problems.
What if this scenario where someone has that
Yes.
and also tonsils and they have, is there any interaction?
No, now you are talking of tonsils. If they are swelling behind the ears, you are talking maybe of mumps. You know, it's possible. Mumps, they do occur and they do regress on their own, mumps. But it's better, I'm happy I've mentioned the mumps, especially boys. It is better to suffer mumps. So if you have a small son, a young boy, and you hear your neighbor, a child has mumps, take your son to visit the friend so that he gets it.
He gets it as well.
He gets it.
It's
When they're still young, they do develop resistance proper. When they miss mumps when they are still young, and they get it where they are young adults, the mumps can complicate by destroying the testes. Then we have destroyed the testes. The impotence and infertility will follow. So it's better the children should get mumps when they are still young.
But there's a possibility of not having them throughout your life.
Well, it's not easy. You will find some people at the age of 40 is suffering mumps. It means he missed all this time. At least if you are 40 and you have 5 children, it's okay. Even if the testes are destroyed, you have got children already. But if you are 30 years and not married and you get mumps, the danger of impotence and infertility is there as a So we want children, young children, to get mumps before they reach that age.
But what are they caused by? So that
it's a viral infection. It's a viral infection.
Because then we can advise
it's a viral infection. So you suffer it once. You suffer it once, and the body develops resistance.
Just like chicken pox and
chicken
measles.
pox, yes.
I caught measles when I was 20.
Oh, you were 20 when you got what?
I was 20.
Chicken pox.
measles.
Measles. Oh, you escaped. But measles, it's okay because,
chicken pox, I was quite young. But I heard between chicken pox and measles, chicken pox is more fatal to adults.
Yes.
Between the two.
Yes. No, it's better you get it when you are still young.
When you are still young. Okay. All right. We seem to have a technical issue. Apologies to our dear listeners and viewers. We are unable to get the cause. We'll work on that technicality next week. We'll definitely give you the service that you deserve.
There are still questions to be asked.
Yeah,
Yes.
please, on behalf of
The audience.
the audience. Now, Professor, when you are inserting that, I don't know what you call it.
Tracheostomy.
Tracheostomy.
We open the trachea.
Where does it sit on the lungs. How does it sit?
No, I told you it's 10.5 centimeters long. And between the rings now, the second, third, and fourth is below what we call isthmus. The thyroid gland on each side is connected. But below that, we can palpate below that, the trachea. We open transverse incision, open, and reach the trachea. And you see the rings, the cartilaginous rings. And you open those rings obliquely. You make a flap. I think our students should listen to this. When you have opened, you reach the trachea. You make oblique incision over the trachea. You cut the cartilages. You open, but you put a silk stitch or a stitch to lift the flap which you have made, like a valve. Once you open, the patient will start breathing in because it's blocked up there in the larynx, has been blocked. So you have now opened the way. The air will flow in, now patient is breathing. But in order to maintain so it doesn't close, we put endotracheal tube or a tracheal tube for the airway, and you fix it in position. So it's hanging within the trachea, but it's allowing the oxygen now to go through the atmospheric air plus oxygen, and the patient is breathing better. But even in that, we have to be very careful where we're going to nurse this patient, because when he's coughing out, the secretions should be coming out. Suction, you can suction using the tracheal tube now. Clean. But if you leave the patient alone, it may block. And if that blockage occurs, it can still kill the patient. So we want it to be, like when in the ward, you want in front of the nurse's desk, very close to the front, so that as they wake on the table there, they are watching the patient with a tracheostomy. Yes. In the case of ENT, we have specially trained nurses to take care of the tracheostomy tube. You have fixed it, and it's meant to save life. Until you treat now, if it is a tumor in the larynx, you remove it, open the airway. If you have to remove the entire larynx because there's a malignancy there, you can remove the whole larynx. But it means your tracheostomy tube is permanent. You will not remove it.
Yeah, I think I've witnessed someone and it speaks through that.
Yes. And you start training them.
Do you have to change it at some point?
Yeah, you change regularly. If you think it's dead, you remove it and put a new one.
But I'm trying to wrap my head around the fact that if you say the entire larynx, which is, it's a muscular tube. Huh?
It's cartilaginous with some cartilages and some bone.
Now, once that is gone, I'm still trying to grasp, how does somebody eat?
Eat. The pharynx is up there. Remember, the epiglottis will have been removed, closed everything, but there's the air, there's a passage of food into the esophagus. We seem to be eating well.
We seem to have a call. Hello?
There's a call.
It's gone.
All right. Yes.
Yes, the pharynx has got, the esophagus going down to the stomach, and the larynx going down to
Professor,
the trachea.
let's see if we can have this call, if our line is now okay. Hello? Hello?
Hello.
Very good. Very good. Yes. Oh.
Amatanga tibagona.
Nga tibagona baliko na asthma na TB bonse benze kumwa banasiriza but still more bamashita mzuo batitabemushe but usiku nge panywa makango opema. Kushita munga wafuna okufa so.
Oh, pepani ndiye kuti usiku paja muntu akagona amachita slow down upema. It's natural, achita slow down upema. Ombangati njira sizotsekuka bwino ingavalike, it's dangerous angamwalire. Please mpite nawo ku hospital mukauze kuti amuna wanga anali pa mankhwala ya TB and info na history ya asthma akapime akamvere mchifuwa mwina niwachita admit one day wachita admit kuti akakhala kuwodi kuja usiku pajamu kuti vimachitika adokota akapime nthawi imeneyo aone chichitika ni chiyani. Amayi msazengereze tumgaluze wamuna
zikoma toto
zikoma gwira ntchito mwana
zikoma kwambiri yangu angatume pa 0972695200 kapena pa 0956520277 tili wokonzeka kutenga makozi yano. I think ankalako bwino line.
Hello, mwaka bwanje.
Bwino mwaka bwa?
Bwino, ine ni nakagoyita njipana kala nyenda kuchipatala kabiri. Na matesti yonse yankala yachitika. But sikani pasa problem ili yonse. So hapa nina appointment ya August. Ngachite bwanje.
Okay mama, goita iyo detu kuti benign. Ndiye kuti irukula pang'ono. But kakali kang'ono tero kachotseni. Ndawa complication inga bwerepo, vuto linga bwerepo, kanga kale kansa kutsogolo. Lomba mzachitanga mwachedwa. Please mupime aone kagoita kalikuti. Kudzanjala manja alo kudzanjala manzere. Nanga karukula motani. Nanga karupushinga trakia mineti lukamba lero. Karuipushinga sicho kama malomo ake. Ma x-ray yako zolongoza ndiposo opima enero pima kuti kodi trakia position yake nanga ko vimba kalikuti andi akakansi kufunika moka penyera tero akachose saditi yembekezere kuti kakale toxic o kakale na cancer yai.
Okay, 0972695200 o kapena 0956520277 ndiye nambara. Hello. Mkwai.
Yeah, Mkwai. And the pocket shako, does BP causes bleeding?
Sorry?
BP.
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 Ila lengo muntu ku bleeding.
Bleeding from where?
Mona.
From mumiona ya. Even sina clot. Mumiona na mukano.
Okay, Alaska. Tumakatinga then move to radio Alaska.
Okay, tisumana tote.
Okay.
No, if your blood pressure is very high, yes, the vessels in the nose can bleed. If it's very high. So it's better to check. And also the bleeding tendency, makamaka ngati mpuno muja, akugirama mpuno. Mulilitus area which has got a lot of concentration of blood vessels. So any touch, you know, the problem with blood pressure is a painless disease. Yet it's a silent killer. And those signs of bleeding and all that, those are warning signs that the patient must be taking medicine to bring down the blood pressure. Sometimes even in the urine you may find blood. Prostate can bleed because of hypertension. And sexuality goes down. Do you know that blood pressure, when a man has a very high blood pressure, sexual performance goes down. That is the system to protect. Because the sexual activity with high blood pressure, the stroke can occur during the action. Wow. So that is dangerous. So the body is trying to warn. The problem with blood pressure, as we say, is a silent killer. So these signs, the patient should take it seriously and go and check the blood pressure.
Wow. Okay, 0972695200 ndiye nambala. Hello, mulipa radio.
Okay.
Hello? Kambisani mdala?
Finish explaining.
Yes.
Okay, I wait or...
Kamban.
Ask.
Hello?
Can you ask, sir?
No, I haven't asked. I'm just trying to call to ask.
That's what I'm saying. Can you ask now?
Okay. All right, okay. Hello?
Hello?
Good morning.
Good
morning.
vuto nifuna kufunsako.
Eya. Funsani.
Okay,
Network.
we can get another call, please.
Network ya vote.
We can try another one, 0972695200 or 0956520277. Mungatume ngatuliko funso pametika kona tuma minutes tungono tome tukaribe kuseka. You want to say something? Professor?
Yes.
Why is it that Bantu Pari, I mean, what's got to explain here, BP?
Yes.
Why is it that people don't really take much precaution, or is it because
no?
It's
I think there's a misunderstanding. When someone has been given medicine and is taking medicine, blood pressure has come down to normal, 130/80. To them, ikafika pa 138, no, napola nilibwino. So waleka. Not knowing that interruption of medicine, it will go higher than what it was. And the studies have shown that people who get strokes, majority of them are those who have been on and off the medications. So as the doctors, we need to explain what is this blood pressure? How do we control it? Do we stop taking medicine? No, you don't stop. Someone who came and said, no, don't examine my blood pressure because I don't want it to know. Because when I know, you will put me on medicine for life. But you see, by not knowing, you will develop complications. It's very dangerous. Blood pressure is controllable. You can't remove it, but you control with medicine. The only blood pressure you can operate and store, we have removed it, is when it is caused by the kidney, and you have identified the particular kidney, and you remove the kidney. Then you know the cause has been removed. But majority of blood pressures is to control them for life.
Wow. And others say,
Mutu wa wawa ndipo ni kumwa. That is what creates a lot of complications.
Okay.
And the complications are at 3 sides: the brain, stroke; the heart itself, myocardial infarction. You wake up and the kidneys have stopped working. So the heart, the brain, the heart, and the kidneys, they are in danger with the patient with blood pressure. Worse still, those patients who have blood pressure as well as diabetes. The two work together to destroy someone's life.
Wow.
But yet, both of them can be controlled.
Both of them can be controlled. Okay, we see if we have the last call. Hello?
Hello?
Yo.
Mwaseza bwanje.
Bwido bwanje.
Nifuna kufunsa pa kwanja kumatonseka so papeo hapa. Ubwera kumukoso. Kusosi niziva ngati ni problem bwanje.
Ni ku left ni ku right?
Ni ku left.
Ku left. Mwina zaka zakati?
40.
40, young man. Very good. At in pain, left shoulder and left side. Yes. We always say left shoulder pain, we must also examine the heart. If there's ischemia in the heart, it causes the pain in spreading or radiating to the left shoulder. So how is the heart palpitation? How is he performing? The cardiac examination must be done. So please mupite kwa dokota wanu, akapime mchifuwa, akapime blood pressure, akapime so mchifuwa kutamvere mtima usevenza bwanji. And azachita ECG and the echocardiogram kutawone ngatuwawa kokocha kumnofuwa mtima kuzapezeka. Mkarandira treatment kuzasiyo wawa.
Wow. Okay, we get the last one. I'm told kuliko ya last. Hello?
Hello, good morning.
Good morning.
I'm calling in Lusaka, from Lusaka.
Okay.
Yeah, my husband is a stroke patient. The problem that he has is good for difficult in swallowing.
Swallowing?
Yes.
Swallowing?
Yes.
Okay.
So the problem that he has, he can't chew properly and he swallow properly. So we have been to the hospital. They are saying the problem came because of the stroke. So that is the challenge that he has.
Okay. All right. Okay.
Atinotizira kumbali yakuti kudzanjala manja udzanjala manzere.
Right or left side?
Right and the right hand and the right leg.
Okay.
They are weak on the right side.
Yes.
Nangolankhula bwino?
He has no speech.
Does not speak.
Yes.
Yes. So you know what has
All
happened.
right, you can cut the line and
Ziko
listen
mamai
from the
Ziko
radio.
mamai
Or
ziko.
TV.
So hii stroke yapanga ku dominant brain. The dominant brain for all right-handed people, all of us who are right-handed, the dominant brain is on the left side. It's the left brain. And it's the brain that carries the speech center. That's where it was located by creation. So this is the most, that's why we are cleverer on one side. So the speech has been affected. But now the swallowing is also, the nerves that are responsible for swallowing are also affected. But nevertheless, we must check the passage of food. So what she needs to take the husband for barium swallow, to take an X-ray when she's swallowing a porridge-like material, which will show the gullet up to the stomach. That should be done. Find out what has happened to the esophagus, the passage for food. But I hope the breathing is okay.
Can that be corrected, or at least
it can be corrected? But we should first make the diagnosis. But keeping at home with those difficulties, the danger is he may start aspirating.
And what's that?
Aspirating means now the food, the fluid start going to the lungs, roll down to the larynx, to the trachea, instead of going down to the stomach.
All right, we've run out of time, 3 minutes before the news headlines. Maybe you can wind up quickly.
Well, thank you very much. And it's unfortunate that interaction was interrupted technically, but we encourage people to call in. The last bit was very good. I hope our students are listening. By the way, Mr. Chongo, I must say, we have a program next week, Monday, teaching methodology short course. So we want the doctors, anybody, the nurses, the health workers, we are going to do teaching methodology short course for 1 week. Please get in touch. Madam Shinondo can say how we get in touch, but PRO, Madam Shinondo, the usual connection to Apex. We are starting with short courses so that we strengthen what we call continuous professional development. And that's what the regulatory bodies want us to do. We have been cleared by HPCZ. We want to improve performance of our workers through these short courses.
All right, Madam Shinondo.
Thank you. Thank you, Chair. Well, just to add on to what Professor was saying, definitely, yes, we are currently enrolling, not just for our usual intakes, but also for the teaching methodology programs. But we also offer other programs which will commence at various times. So to find out more of these other courses, because we have now introduced short courses. We've begun those, but it is quite a long list. They range from anything between basic first aid to anything within the spectrum of pharmaceutical courses. It's really quite vast. Okay. I can only just, it's a long list.
It is indeed.
That's how impressive. So, if anybody's interested in finding out more or actually enrolling in not just teaching methodology, but also to find out more about our other programs, they can call admissions on 097-413-7203. I'll say that one more time, 0974-13-7203. So, now that we've touched on trachea, bronchi.
Bronchi, yes.
So now that means we'll go to the bronchial and alveoli.
Yes, we are going bronchioles and alveoli, but we have segmental bronchi first.
Okay.
Yes.
All right, thank you. And it remains for me to thank my guests in the studios, Professor Taxon Lambert and Madam Shinondo, and not forgetting the entire production crew, Andrew Chone on the cameras, and also Messi Mshanga on the techniques, together with Mr. John Smabudu. And at the studios at Lumen TV, we have Esther Mpanisi. Thank you so much for joining us. And also, I don't forget to thank the three directors who are executive producers of this program, Father Winfield Kunda, Father Fanwe Olungu from Chipata, and Father James Daka from here, Lusaka. Bye, and God bless you. Enjoy the rest of the programs.
Oh, Queen of Radio Maria, pray for us.
COVID-19 is real. Protect yourself and others by wearing a mask, washing your hands with soap regularly, sanitizing, and social distancing. This message is brought to you in the community service by Radio Maria Yatsani Voice.
Oh, Queen of Radio Maria, pray for us.
News on Radio Maria Yatsani Voice.